So patient selection, how do we pick patients for atrial fibrillation ablation? Well, first of all, they have to be symptomatic with their atrial fibrillation. So if somebody's been in atrial fibrillation for several years, 1, 2 years, generally what I'll do, first of all, you ask the patient, how do you feel? Do you think that this atrial fibrillation is causing symptoms? Once you've had it for that many years, generally you don't know if it causes symptoms or not because you're used to the way you feel. What we'll do is we'll generally try to cardiovert them, maybe even on amiodarone if they've been in atrial fibrillation for a significant period of time. Sometimes amiodarone is the only thing that will really hold them in sinus rhythm. We'll keep them in sinus rhythm for a couple months, make sure they feel better, and if they come back to me and say, Doc, I feel better than I have in years. I don't want to go back into atrial fibrillation, then we'll offer them an ablation in order to get them off of amiodarone. So that's generally how we'll do it. We'll make sure that once we get them in sinus rhythm, they're going to feel better than they did when they were in atrial fibrillation. Then there are some patients that we get them in sinus rhythm and they really feel no different than they did in atrial fibrillation. And at this point in our knowledge about atrial fibrillation and atrial fibrillation ablation, there's no indication to do an ablation or keep them on any medications just for the sole purpose of maintaining sinus rhythm. You really have to have some symptoms in order to justify the danger of antiarrhythmic medications and the risk of atrial fibrillation in order to really offer that to your patient. So refractory to at least one class 1 or class 3 drug, and this is a relative indication for selection. I generally say refractory to at least one class 1 drug or dronedarone, so the class 1s being Rhythmol or flecainide, which you can give in the outpatient setting, and Multac you can do the same. Class 3 drugs, generally, unless they have a defibrillator, I at least admit them for a day or two. For Sotalol and for Ticastin, you have to be in the hospital for 3 days. So I generally offer my patient an ablation kind of equivalent with one of those drugs. Age under 75, probably the oldest patient we've ablated now is 83 years old. But they're a very healthy 83. They play tennis. We don't want to, somebody that's bedridden, obviously, because we're not going to do them any good. We're not going to improve their symptoms if they're not doing anything. So age greater than 75, under the age of 75 is a relative indication. If they're very active and healthy, then we'll go older than that. But they could be 65 and not active at all, and that's not a good patient for an atrial fibrillation ablation. Left atrial diameter, so if you have a very enlarged left atrium, then it's much harder to keep that patient in sinus rhythm just because they have a lot of scarring and fibrosis, and those patients generally don't tolerate being in normal rhythm for very long, and they end up going back into atrial fibrillation. If they've had atrial fibrillation for years and years, those are much less likely to be maintained in normal sinus rhythm. So those patients are going to take often more than one ablation, so they have to understand that. Paroxysmal is much better than persistent as far as our results overall are concerned. Advanced structural heart disease, so if they have severe mitral regurgitation or severe aortic stenosis, they're going to need surgery. It's much better for them to go ahead and get a concomitant Mays procedure during surgery than us go in and do an Afib ablation and then them get surgery soon after. So those are the patients that we definitely refer to the surgeons and tell them to go ahead and do their Mays procedure at the same time as surgery. Anybody have any questions about kind of patient selection and how we choose drugs and choose catheter ablation?